cancer by looking at the diagnosis. We know we can diagnose prostate cancer by using your prostate-specific antigen, the PSA, and we've gone through the numbers regarding that. Okay. We can also look at your SAP, which will be your serum alkaline phosphatase. In prostate cancer, the SAP will be elevated. Okay. So if you're talking about like 130 to 190 international units per liter of SAP, that would be suggestive of prostate cancer. Normally, it should be somewhere between 30 and 130 on a normal basis. But if it's getting up to 130 to 190, you probably have prostate cancer. This would suggest that it has actually gone into the bones, because that's what you're looking for in your SAP. And then you have DRE, which is direct rectal examination. Okay, and that's when the physician will stick their finger into the rectum to try and feel the prostate. That's why I said the location of the prostate plays a major role here. And that's the only time you should ever allow anybody to give you the finger when they go in there. So you have TRUS, which is the transrectal ultrasound. So you're using the ultrasound basically to create an image of the prostate gland so you can see it. And then, of course, biopsy. And this is very important. There are people, I've seen people that had a PSA, not just 10, but in the upper teens, even in the 20s and 30s, and they're still living normally, they don't know anything. And then they go to the doctor, they say, okay, your PSA is high, and we have to do a biopsy. Okay, and they do a biopsy, and they said, okay, well, your biopsy is normal, which means you don't have prostate cancer. If that happens, you probably need to get a second opinion, because sometimes the tumor is located on the inner side where an initial biopsy may not detect it. Okay, so a PSA that is very high, and you go and they said they did a biopsy, nothing. Have one or two other people check it out. Okay, and then you can do some bone scan. Bone scan, again, this is to determine metastasis. Okay, and one can do a chest radiography. That would be to detect metastasis to the lungs. Okay, so and then you can do a liver function test, which will detect metastasis to the liver. Okay, so because we said prostate can spread to the bones, the lungs, and the liver. Okay, so that's why you do all of those to confirm the metastasis of that cancer. that's in terms of the diagnosis. And if we look at treatment, the treatment modalities can be surgical, so we can talk about surgery, or you can talk about radiation. It can be used. And then you have treatment that is using drugs, drug treatment. In terms of the surgery, one can use what is called a cryosurgical process. Okay? And cryo simply means freezing. Okay? So they freeze the tumor and then it can be easily ablated or cut off. So that's cryosurgery. One can also use a resection of the prostate. Okay. A resection of the prostate. And sometimes you can see that referred to as TURP, you know. So you go through the urethra to resect the prostate. Or one can do orchiectomy, which will basically be the removal of the testis, you know, so that the prostate cancer can be avoided. So all of those can be used in terms of surgery. Radiation, you can use either a systemic type of radiation, or one can use an external beam. For the external beam, you're probably just using iodine 125, you know, I-125. That can be beamed externally, that is through the skin to the prostate. So, or one can use the systemic, in which case you can use samarium. Samarium 153. That is used systemically. You're using radioisotopes that can target the bones when you're doing systemic radiation. Okay. Strontium can also be used. Strontium 99. That can, 89. Strontium 89 can also be used for the, no, strontium will be external. Okay. So those can be used for radiation. Now with drugs, the drugs we've seen, you have them listed in there on your handout. You can use hormonal management for drugs. But the first one we've listed there, the PARP, those are ones that we've already discussed many times. Olaparib, we've discussed under breast cancer. So your PARP inhibitors can also be used in prostate cancer. And anytime you use a PARP, you have a time limitation. It's always used for just 2 years, no more than 2 years when you use the PARP. So you can use olaparib, and we've listed a lot of your PARP inhibitors before. The 5-alpha reductase would simply inhibit the conversion of testosterone to DHT, and of course you have all your dutasteride, finasteride. That can be used. There's a product called Jalin, which is actually a combination of dutasteride plus your alpha 2 inhibitors. So the 5-alpha reductase inhibitors they do not actually help to treat the prostate cancer, but they can reduce your risk of getting the prostate cancer. You can get a 25% reduction in rate for the development of that prostate cancer. Of course, they're designed to shrink the prostate, but they're not really designed for the complete treatment of prostate cancer. In fact, if you use a 5-alpha reductase for too long, it may even increase the virulence of the prostate cancer. Okay. So the best at the early stages to prevent, the increased growth of the prostate. But if the prostate cancer has been established and you use a 5-alpha reductase inhibitor, you can actually worsen the situation. And we know that the one that is available over the counter, the saw palmetto, can also work at that level, that is to inhibit 5-alpha reductase. The alpha blocker in your Jalin is just to relax the muscles of the urethra to increase the flow of urine. Okay. It is the 5-alpha reductase that reduces the size of the prostate. And estromycin, we won't say much about that. It's basically obsolete. That's a high dose estrogen that is usually combined with a nitrogen mustard, like your methchlorhythamine. So that's the estromycin. So it's estrogen plus an alkylating agent, nitrogen mustard. It's basically obsolete, but there is, I'll just add it in here. There is a combination drug that uses paclitaxel and your estromycin. It's really no longer used. Oncorad Oncorad is a combination of a monoclonal antibody with your yttrium. Yttrium, of course, is a radioisotope, yttrium-90. So it's a combination of that monoclonal antibody and yttrium. Oncorad itself is essentially obsolete also, but you do have this yttrium being combined with Ibritumumab. But that's for your NHL, that is non-Hodgkin's lymphoma, not for prostate cancer. Okay. So the use of yttrium is still there. It's just that not in the formulation of Oncorad, but more in combination of Ibritumumab for non-Hodgkin's lymphoma. And so we look at the hormonal therapy, which can include your androgen antagonists. The androgen antagonists you can divide into two, those that are steroidal and those that are non-steroidal. And again, those are listed in your handout. Sapropteron, I don't think is shown in there. Okay. Sapropteron is a member of your steroidal androgen antagonist. Okay. And then abiraterone is another member of your steroidal anti-androgen. If it's steroidal, it means that the antagonism is non-competitive. Okay. So if it's steroidal, it will be non-competitive, and if it's non-competitive, it will mean that it will be non-reversible. Okay. Just the same way we mentioned about your aromatase inhibitors. Those that are steroidal will give you non-competitive antagonism, which will mean that it will be non-reversible. So we have abiraterone, we have sapropteron, but they do work differently. Okay. Sapropteron will antagonize your androgens at the receptor site. That's where it would work. Unlike abiraterone, which will inhibit your 17 alpha hydroxylase. So basically, Zytiga, which is your abiraterone, would inhibit the synthesis of the androgen. And it will do that at the level of your testis, your adrenal gland, and also in the prostate cancer itself. So that's a 17-hydroxylase inhibitor. We've gone through the biochemical pathway in PODA2. You will remember from your cholesterol, you can get pregnenolone. Pregnenolone will go to hydroxypregnenolone. That enzyme works there. Okay. And then your hydroxypregnenolone can be converted to DHEA, okay, dihydroepiandrosterone. Again, the 17-hydroxylase works there. So that's why we say that your abiraterone can inhibit the synthesis of the androgens. That's how it antagonizes, or why we say it's an androgen antagonist. Okay. And as you say, abiraterone can be administered by itself, but it is very often given with prednisone, okay, for good therapy. And then we're having their megase or megestrol. Megase, of course, is a progestin. And if you remember again from PODA 2, your progestins would interact with their receptors. You can have PRA and PRB, progestin receptor A, progestin receptor B, and we mentioned that your PRA is inhibitory, but PRB is stimulatory. Okay, so that's why megase can actually inhibit or antagonize your androgens at the receptor site. Then the non-steroidal agents, the non-steroidal agents are the ones that we call the glutamides. The glutamides. And if they are non-steroidal, it means that they will be giving you competitive inhibition. And if it's competitive, then it will be reversible. Okay? So non-steroidal will be competitive antagonism, and of course, competitive antagonism can be reversed. And we call those agents the glutamides because you just have to add something to glutamide. For instance, if you add F, you get flutamide. Okay? If you add Ni, glutamide. Okay. So maybe I'll teach you one word in the Nigerian language. In Yoruba language, Apa means arm. Okay? So if you say that flu will bend your arm. Okay? Apalutamide, flutamide, bicalutamide, okay? Enzalutamide, nilutamide, and darolutamide. And in Yoruba language, if you say Odaro, that means good night. So darolutamide, it will be one of your non-steroidal agents. So the non-steroidal androgen antagonists tend to basically antagonize the binding of your steroids, that is your androgens, to the androgen receptors. That's the mechanism of action there. Gonadotropin releasing hormone analogs. These agents will initially cause an increase in your androgens, and then over some time they will cause a decrease. Basically, you use up the system. Okay, so you get an initial increase and then a drop in your androgen activities. And those ones that are gonadotropin releasing hormone analogs. Those are the relins. So those are your relins, and then we have a little mnemonic that seems to work for students or has worked in the past, and you will see one that says goes on his bus and on the bus trip. Okay, goes to railing, naphthalene, hysterelin, bus railing, and triptorelin. All of those are your railings. And then who goes on his bus? Leuprolide. And those agents, like we said, can cause a little increase before you get the decrease. And they're all effective in prostate cancer management. Naphthalene, this one, naphthalene is more used for endometriosis than for prostate cancer. And that's one that can be administered intranasally, okay, for the management of endometriosis. And then the gonadotropin releasing hormone antagonists. The main agent here is aberrelix. You have one that is also called Degarelix. And those would basically give you a decrease in your gonadotropin concentrations, and they can antagonize your androgens at the receptor site. So if you're talking about gonadotropins, you're talking your FSH and LH, which of course can affect androgen production. Now, elagolix belongs to that group, but it is mainly used for endometriosis, not for prostate cancer. Relugolix that's perhaps the newest member of the group, and it stands out because it is one that can be given orally, can be given PO. You normally give an initial dose of 300 milligrams per day on day one. That's the loading dose. And then you give about 100 milligrams on a daily basis, 1 to 150 milligrams. Take it as 150. So you give 300 loading dose, and you can give about 150 milligrams on a daily basis. Right now, relugolix is the one that is being touted basically as the best among those gonadotropin releasing hormone antagonists. If you really look at it, their mechanism of action is also at the receptor site, so very similar to your androgen antagonist. Okay, sipuleucel. That is a different animal because it represents what you call autologous system or autologous cellular immunity. Okay. When you say autologous, basically it means from the same person. That is, the donor is also the recipient. Okay. So you're using the individual's immune system to treat him. If it's been a minute since you had basic immunology, you know that if a foreign subject gets into the body, your antigen presenting cells will pick up that invading organism. And the APC will then present the antigenic part of that invading organism to your nodes. Okay. At the lymph node, you have 3 segments of your lymph nodes. Okay. So you have cortical, and you have germinal, and you have your paracortical segments of your lymph nodes. Where the APC would take that antigen to depends on which immune system is supposed to be stimulated. For instance, if what you need is a T cell activation, the APC will take the antigen to your paracortical system because that's where your T cells are. Okay. If it's cancer related, what part of the immune system fights off cancer? Your T cells. So that's where we take it to the paracortical segment of your lymph nodes. If, for instance, it were a bacterium, that requires a B cell activity. So your cortical and germinal segments of the lymph nodes, that's where your B cells will be. Okay. If you look at the prostate cancer, the prostate cancer can elaborate this prostatic acid phosphatase, or what you call PAP, PAP. PAP is actually representative of an antigen from your prostate cancer. All right, so if you take this PAP and you incubate it with that APC, the antigen presenting cells, okay, and then you want that combination to grow very well, you incubate that with your GM CSF, okay, your colony stimulating factor. This whole system the PAP, the APC, and the GM-CSF is actually what that drug is. And it's available under that brand name, Provenge. So that's your Provenge. And that's why you say it's autologous, because you're taking all of this from the cancer patient himself. Okay? And you activate that APC with your GM-CSF, and then you reintroduce it back to the patient. That's why it says autologous. So it is patient specific. And you always have to triple check the name on the bag to make sure that this is the correct patient, because it's only designed for that one patient. It's autologous. Okay, so when you do that, then you can, of course, give it back to the patient by IV infusion. The IV infusion will be administered over 60 minutes. So it's slow IV infusion, and will be given every 2 weeks for just 3 doses. That's how much they get. Okay. And what are you looking for? You will be looking for what is called ICAM, or ICAM-1, that is intracellular adhesive molecule. Okay, intracellular adhesive molecule. That's what will be elaborated on the surface of that APC. Remember, it's the APC that is carrying this antigen. And you will be using about 50 million units of that elaborated or produced ICAM-1, and that's what will be diluted in 250 cc's of your Ringard lactate or lactated Ringard solution. So that will be in 250 mLs of lactated Ringard solution or Ringard's lactate solution. And that's what will be infused over 60 minutes every 2 weeks times 3 doses. So that's your Provenge. And when you give Provenge, you will get certain things. You will get an increase in the number of your APCs. So in other words, this incubation system, because of the colony stimulating factor, would let you see a large increase in the APCs. So you get an increased APC. You will get an increase in the number of T cells that will be produced. You will get an increase in the migration or the movement of those T cells towards the cancer cell itself. So all of those will be increased. And then you will get the production of memory cells. Okay. So memory T cells, you get an increase, which basically means that you can get an amnestic response. All right? So that's all basic immunology, actually. An amnestic response basically means that your immune system is primed to attack that antigen the next time it comes. So you get an exaggerated response against that particular antigen. Okay. So that's what you will get with your Provenge. And don't mistake Provenge for Nuvenge. And not for Privigen. And not for Privigen. Nuvenge is actually a breast cancer immunization system that is being developed now. And it uses this same system. It's just that instead of your PAP, it uses HER2. Okay. It uses HER2, and then it is infused back into the patient, and that is supposed to actually help prevent breast cancer in patients that are highly prone to it due to their family history, like that. That's your Nuvagen. Okay. And of course, we know that Privigen if we just break it down like that, it is your immunoglobulin, that is IG, that is administered IV. So that is an immunoglobulin drug that's used to fight off infection. And of course, Prevagen, if you break that down that way, is something that prevents aging. Okay, that's an over-the-counter drug that people take for increasing their memory sharpness, if you will. So that's OTC. So those four sound about the same, but they are totally different. All right, so these other two agents are essentially investigational, so we won't say much about them, but you do have an inhibitor of the lyase action of that CP17A, that is being tried right now. And the Provicol is something that is believed to be a game changer in the treatment of prostate cancer. That is also being tried, but those are not on the market yet. I just had to mention them. Then you have some combination drugs, of course, that you can use for prostate cancer. That would be your flutamide plus luprolide. See, these are sometimes what you call CAB, combined androgen blockade. You're using two antagonists of androgen, to manage the cancer. Okay, and of course that's flutamide plus Zoladex. Okay, that's your goserelin, Zoladex. And you have here bicalutamide, which is Casodex, plus your glutamide here. And this is bicalutamide and goserelin. And then you can take prednisone as the backbone drug and just add one of these other four that one can use. Let me get over here. The last agent that we want to mention in that regard will be ipilimumab. You can see it as Yervoy. Of course, it will be a monoclonal antibody. The reason your immune system, say your T cells, the reason your T cells don't attack your normal cells is because you have a system that you call the off switch. For your T cells. That's why your T cytotoxic cells will not attack your normal cells. And there is a switch that keeps keeps your T cells from attacking your body or your normal cells. And that off switch, you have one that is called CTLA4, which means cytotoxic T lymphocyte associated antigen 4. Cytotoxic T lymphocytes associated antigen 4. So CTLA4 is an off-switch system. Okay. So if you give Yervoy will inhibit CTLA4. Okay. That basically leads then to the activation of your cytotoxic T cells, which will then annihilate or destroy your cancer cells. So that's how Yervoy works. It is used in prostate cancer, but it can also be used in your non-small cell lung cancer. It can also be used in skin cancer. It can also be used in esophageal cancer. Okay. And very often, it is combined with nivolumab, and the brand name for nivolumab is Opdivo. Okay, so this combination you can very often see used together for the treatment of your prostate cancer and small cell lung cancer and skin cancer and esophageal cancer. Okay, so that's another one that we want to mention there. And we'll hold it there. But like we said, under breast cancer, you do have certain classifications for your prostate cancer. It can metastasize, of course, in which case you will see the small m used, metastatic prostate cancer, okay? And sometimes it is resistant to androgen. So you can see AI, that is androgen resistant or androgen insensitive. That is, the prostate cancer is not sensitive to androgens. Okay. And you can see one that would be so-called castrate resistant prostate cancer. So it's resistant to castration. All right. And fortunately for all of those, your Provenge is actually very effective. So you can use Provenge for all those categories of your prostate cancer. All right. Questions? We'll do cervical cancer next time. All right. No questions? Okay.